You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the Pre-Hospital Care podcast with myself, Ryan Walker. In this session, I'm speaking with Andrew Pearce on the trauma handover. So what we wanted to do in the session is examine a definition of handover, the commonly expected barriers to effective handover, the recall of handover information, and also where handover occurs. We also want to examine the standards and recommendations for handover, also the tools and templates which are commonly used, how we can measure effectiveness in handover, and finally where it works in practice. What we also wanted to do is just look at some of the empirical literature, examining some of the evidence behind handover. To do this, I have Andrew Pearce with me. Andrew is an emergency physician and pre-hospital retrieval medicine specialist. So he currently works as a clinical director and the Medical Retrieval Consultant Coordinator at MedSTAR Emergency Medical Retrieval Service based in Adelaide, Australia. Welcome to the podcast, Andrew.
Thanks, Ian. Good to be here.
Andrew, I just wondered if I could firstly get you to speak to a working definition of handover, if possible.
Sure. If we look from a Google definition point of view, you put in handover, you'll get a couple of million different hits. And it's trying to find something that resonates to understand the process that we're going through. And the one that I think kind of resonates for me is that the act of moving power or responsibility from one person or group to another, and the period during which this is done. So it's understanding that it's not just the spoken word, but you're actually transferring. You know, if you take it down to a level of pilots, pilots say handing over, and the co-pilot will say taking over, or the pilot that's taking command, and they'll give it back. So it's a recognising of the information as well as the responsibility that's being imparted, and the time that this is being done. And I think, you know, one of the things we will hopefully look at is expanding on what that time is during the period of handover.
It's really interesting you say that, actually, Andrew, because like you said, it's not just the passage of information, but the passage of responsibility as well, and indeed power. And I think that interplay is commonly seen, but not necessarily successfully occurs in practice, because so there's two or three different agendas happening when a patient's handed over, this transfer of power and responsibility and transfer of information. I guess an adjoining question to that, Andrew, would be why are these transitions so tricky? I mean, I suppose number one, we've just mentioned there's two or three sub themes occurring at once here, but you know, we initially met, we're in the London Trauma Conference, and you said, you know, up to 70% of clinical errors can occur in handover. Could you maybe speak to why these transitions of care are so tricky?
Sure. And I think, you know, a lot of this work's been done by a lot of very smart people before me, and taking from the literature. You know, Sue Evans's group out of Victoria with Mark Fitzgerald have looked at it at some of the effective and ineffective ways. And I think if you look at the ineffective ways, you picture yourself in a room with a lot of people, and there's a lot of hype going on, and everyone's expecting something, and their expectations are quite high. There's interruptions. There's background conversations going on. There's not active listening. There's people that are kind of got one ear in, but they're kind of thinking about something else at the same time. The team size can be small or large, and I think, you know, the larger the room, it's normally the more sexier the trauma. You know, it's amazing how a gunshot wound or a knife wound that goes out on the pager, all of a sudden you get a rent-a-crowd. And I remember in Ryder Trauma Center in Florida, where they actually had a security guard not to stop members of the public getting in and out of the resus room. It was actually to stop onlookers of medical staff, because they had too many people in the room to manage. The other things that I've seen, and I gave some examples during my talk earlier in London, was the seniority of someone giving the handover and the seniority of who's receiving the handover. And it becomes almost a performance play where it's not about you, but it's about the information that you've got and how you can get that across in a concise fashion. And we find that people that write something down or have a structure to it are able to impart that knowledge pretty effectively in a good time. and also keep the room interested. Whereas someone that doesn't and is more worried about how they're being perceived is likely to try and memorize bits and pieces and then try and throw it in a top-to-toe fashion and pull bits of information in. And because it's not in a structure, it makes it difficult for people in the room to follow. It makes it difficult for the scribe to capture it in a format, and you can see how people lose it. The more experienced the people are in the room, the more structured the process, the more succinct the details are, and again, the confidence of the person giving that handover, I think, addresses some of the issues that you can see where it goes off the rails. So it's a multifactorial thing, and you would think something it's relatively simple, but you have to have the audience primed, and you have to be in a position whereby you're ready to impart that information, knowing that you're going to lose people pretty quickly. And I don't know that everyone can do that really well. And I think without training in it or practicing it, and certainly now we've inserted it in the curriculum for pre-hospital and retrieval medicine courses and diplomas and postgraduate certificates. And we've also put it in our induction course of 2 weeks, whereby you'll give case cards. They'll have the registrars or the nursing staff or the paramedics will have to glean the information, put it in a format, and then do a handover. And that structured process and practicing it means that you feel confident. And one of the things I did in London was I showed a couple of videos of different people in different stages of their life, not right or wrong, both could be improved upon in many ways, but just looking at how people attack it. And it's a really powerful thing. And I think for people that have ever studied for vivas and they get themselves filmed and replay it back to us and they cringe and they don't like the sound of their voice and how they're looking, but it is really powerful to see how you are performing and whether your voice, whether your tone, whether the speed at which you're speaking, all of those nuances can have some effect on making it a really effective handover.
Andrew, could you speak to some of the statistics on the information accuracy, because you really brought this to a fore in London when you spoke at the conference around sort of accuracy of information, and we will get onto retention shortly, but could you maybe speak to information accuracy?
Absolutely. A few slides that I put up, that we've got a problem is, and a quote from the paper by Sue Evans and the team from Marks Fitzgerald at the Alfred was, even when paramedics are provided with training on how to hand over, information recall by the receiving team has been found to be as low as 36% of the paramedic verbal report. 36%. Okay, so 1/3 of what was said is retained in a handover. And that's with the paramedics being actually trained to do that handover. So it's not like someone that is a junior paramedic doing it. It's someone that's gone through active training. They've got a structured process, but the retention is only 36%, which is scary, because if you think of that point in time to be a patient advocate and you're trying to impart that information that you may not get from the notes, that this is something that's happened at the scene or en route. It's not all written down. This is your one time to glean out information, and you're losing 70% of it into the air is not good. Of all of the questions asked of the person handing over, 35% of questioning previously given information. So the information's been given, but they're still questioning 35% of the time. The majority of handovers, 61%, involve parallel conversations between team members while the pre-hospital team was speaking. So if things are going on in the background, you're not actively listening, the information's being imparted, and then you're being rude to the point that you have to re-ask information in the handover. And you can imagine what that does. This is people that don't know each other. This is teams that are formed. And even we know that resus teams that don't spend a lot of time training, they get thrown together on each of their shifts. And now you've got the interplay between pre-hospital and hospital. You've got someone not paying the respect to the person giving the handover. And you can just see where, the whole vibe turns, and really the room is not a functioning room. And you can see where people giving handover might actually get a little bit peeved that they're not being paid attention to, and maybe even give up in that process. So it's a very vulnerable time, and I think it's something that we really need to pay more attention to actually to get it right. When doing high fidelity SIMS in the emergency department, they determined that 18% of the information handed over to the newly arriving personnel was inaccurate, and only 67% of the information handed over was accurately documented. So it's a real error-prone environment in giving the information and then receiving the information. Because how do you know that what you've said has been interpreted or written down to the level that you've actually given it? So it's a very vulnerable time for the patient, and it's a time when information can be lost. And I worry that some of that information that is lost may have an adverse outcome on how the patient is treated or the pathway that patient goes down.
So, Andrew, you bring up a lot there actually around information entropy, really, just this information which is lost to the environment. And some of the really interesting observations you make is around background noise, because we know the pre-hospital transitioning to the in-hospital environment. Pre-hospital is noisy anyway, but then bringing that into a crowded room of people, lots of information lost. Recall and retention is poor. Information accuracy can also be poor, and as you said, the absence of structure can cause a loss of this information. So I suppose the antithesis of that, and my question would be how we can combat that. Would you suggest brevity, structure, silencing the room, and maybe a recall or closed loop communication indeed of this information?
I think it depends where you are. It depends what your demographics are and what you're seeing. Because, if you are a major trauma centre, you should probably have some relationships with the pre-hospital providers to know what information that the receiving team want, and you should have an agreed format and how that's delivered. I think that's part of the battle there. If you know the language that you're going to use, you know the structure that you're going to put it in, then it's better. You're expecting it to be delivered that way, and you're expecting to deliver it that way. Controlling the room is difficult, but again, it's the team leader's responsibility. And we don't put people in the team leading role unless they've got the experience to do it. Otherwise, you're setting the room up to fail. It's much like what we used to do with the scribe nurse. The scribe nurse, or the scribe in the room for the hospitals that I've worked at, many years ago used to be the most junior person. Now it's the most senior person. And I know Mark Fitzgerald and his team at the Alpha has done a lot of work on making sure that the scribe is almost the central focus of the whole thing and actually keeps the rest of the room ticking. So you've touched on a couple of things. Noise, and it won't work unless there's no noise. And the more people you've got, the more hard it is to control them. Succinct, absolutely. If you can't get your message across in like 90 seconds, from start to finish, yes, you can be asked questions afterwards when you've packed up your ventilator and moved back and then come into the room, or you hand the notes over. But if you can't succinctly get across what you need to get across in that first brief period of time, you're going to lose people in the room. They're not going to be respectful enough. They're going to feel like they have to crack on. They want to get some monitoring on. They want to get that therapeutic vacuum to be stopped, and they want to start moving on. So getting the room to be quiet, setting the standards around what's actually happening. So I think one of the good ways of doing that is if the team leader sets the boundaries to the people coming in. Okay, we've got a patient being handed over. There'll be no touching of the patient. We're ready for a handover now. Are there any immediate needs? No. Let's go on. Scribe takes down the information. We actively listen to what's actually happening. There's nothing going on with the patient at this particular point in time. We get that information down. Are there any questions? Are there any clarifications? Let's move on. And then you've captured the information on the whiteboard in the room, because I think whiteboard is really key, because people learn in different ways. Some people learn by the hearing, some people learn better by seeing, some people learn better by the kinesiology of actually touching. So we have to look at the way people learn and the way people take information in, so that we get that right And that may be a multifactorial process. So they're listening to it, they're seeing it being written down. And one of the things that, I've stopped doing in our room is, the handover process used to get interrupted every time a new person would come into the room. Surgeon would arrive late. The theatre staff would arrive late, and everyone wanted to hear the story over again. And I point to the board, because if you've got structure and brevity and you've got the clarity of what's up on the board, that's what the information is, and you need to actually pick it up from there. You can't just make this happen by individuals, though. I think you need to, as we said, from a pre-hospital point of view, have a structure. Have that structure accepted by the receiving hospital, and then practice it. Practice receiving and practice giving, and making sure that everyone gets a crack at doing it. Because, there are some studies looking at EDs and having simulation teams. And even in the simulation environment, as I pointed out earlier, you still lose information. And again, it's like practicing as a trauma team. If we are individuals that are thrown on a trauma team at the beginning of a shift, how do we know how well we're going to function? Qantas pilots are quite interesting. They never fly together. There's hundreds and thousands of Qantas pilots out there, but they go through sims so that they know that when they get into the cockpit and they're faced with a challenging situation, they revert to their training. They know exactly the drills that they need to go to, and the conversation and the words that they use and the language that they use make sure that they're safe in that environment. We need to do more of that training in our environment. We say that we don't have time. We say that we're busy. We say that there's too much going on. If you want to get this right and you want to make it better for your patient, you can't pay lip service to it. You actually have to do something about it. It's a very complex environment where there's so much information. There's so many parameters going on. We're talking about, hanging on to the spoken word, but how do you get the other things right? How do you get the trends of the observations? One of the ways we do it is we print out our vital signs monitor and give a copy of that so that we know that we're giving across. We're not just making up numbers. The old days of writing on a patient chart of the systolic was 120 and the SATs were 99. No, what were the SATs? They actually dipped to 86 and the pulse was 140 at the time. So that true information needs to be handed over, and that is something that forms part of the physical handover of the information, which is backed up from the verbal handover that we're doing. So I've given you a lot there. I'm hopefully have covered off on a couple of those areas.
Something you said before, actually, Andrew, around the bias of information, also just the bias and maybe presupposition of pre-notification message. So we know, and very much yourself working in the pre-hospital domain, the information you get initially from a call, or indeed from a ground ambulance, or from a clinic, or indeed from a 999 or an emergency call might be biased itself. It's subjective, it's set into a format, but very much anyone who's practiced pre-hospital care for a long time knows that actually the information coming at you isn't necessarily the information you see on the ground, and actually it's prudent to not practice bias in that phase of care. How important is it to not practice bias from a snippet of a pre-notification handover in a trauma bay? So you might get 45-year-old male stabbed chest, X, Y, and Z. How important is it to sort of maybe clear your mind in an emergency department? Because it's a different setting, but it could be the same presupposition or same bias and tilt of the information before you see a patient.
Absolutely, and I think you've led me down the answer to the question or what I want to talk about. Bias is everywhere. And one of the things that we do, and if I take my role as an emergency physician, when I'm working on the floor and a junior has to run a case by me, whether it be a resident or a registrar, they're running the case by you, and I, they give their differential and I say what I think. And they latch on to everything that you said, and they latch on to what you think the plan is and impart it. And I spin it around straight away and say to them, well, question me. Why are you accepting that what I've got to say is what should be done? You need to actually be able to question everything. And bias, I think, gets us everywhere. And your example there, stab, I've got people in the room that are already at thoracotomy by the time they heard the word stab. Whereas we know stab can mean a number of different things, from the implement that's being used to the area that's of the chest that's been impaled upon, and the kinetic energy that was used. So it is really tricky. And I think a lot of people want to action what they've heard rather than build a picture from the information that's given. When we heard about the Bali bombings, and I'm one of my other roles as an Air Force doctor, and Bali bombings, in the early 2000s, with a sad loss of life in Bali. One of the first sit reps that we heard was that there'd been a barbecue gas explosion with, cooking of food, with 6 people injured, which, then went on to, several hundred that had actually died in a terrorist act, from explosions within, nightclubs. And it's interesting, over time you get more information, and these pre-notifications can be so wildly inaccurate, but they do anchor us, and they do throw a bit of bias in. And then you get the confirmation bias when someone else says, oh yeah, it should be that, and we should set up for this and we should do that. And it's really easy to get a team of independent thinkers all of a sudden got the Borg mentality, and they're all on board with the same idea. And I think that's dangerous. So, you want people to question, and you want people to ask, well, why are we thinking this? Or why shouldn't it be this? Or why don't we open our minds? And I think it really takes the leader to say, we need to question, or we need to clear our ideas of that presupposed path that we're going down, because it can really lead you into perhaps doing things that you shouldn't be doing, because you've already anchored onto this, and you think, well, this is the pathway. We've confirmed it with everyone else. Let's go. So you need those checks. Easy ways to do that, or easier said than done, is the time out. And we teach this a lot in the pre-hospital. When the patient's not dying at this particular point in time, but you really haven't got control of the situation, and there's lots going on. As a team leader, read the room, read the situation pre-hospital or actually in the trauma room, and be able to have the ability to say, stop, we need a timeout. We need to actually reevaluate where we are. It's like going back to the ABCs, you used to teach us on the trauma courses all those years ago. It's that ability to have the bandwidth to say, I'm overloading, but I'm going to get rid of some of that. I'm now going to focus on where we should be, and I'm resetting before we actually move forward. I think that is hard to do, one thing, once a case gets momentum and people start doing what they think needs to be done, because everyone's got a role to play. So they just get on with what they need to be doing. But is the team doing what the team leader wants them to do? And how do we know that they're all on the same pathway? And that's where I think talking out loud and being able to share that you're all on the same plan. And that's again, from my point of view, we do read back, and read back is quite important. If you haven't grasped all the information that's there, questioning, to be able to say, have we got this right? Have we missed something out? Because as we said earlier, it's not only the receiving of the information, it's the giving of the information. Sometimes that information can be given in the wrong way. And if it's given in the wrong way and then acted upon, then we're just complicating the errors. So, a lot to it. And I think, the way I look at it from a hospital point of view is, when I start the shift in the morning and you do your ward round and you've got everyone there, even if there's still some patients in the room, use that time to be able to get some of these points across, to set the scene, to say how you're actually going to play out your day, how you're going to run it, and what the roles and responsibilities are. And I'm amazed at some of these very simple ward rounds that we have, where you'll start a conversation like this, that you think everyone knows what's going on, everyone knows their roles, but all of a sudden you've got a whole conversation asking questions and getting involved in, how we're going to structure this, how we're going to do this for the day. I think it's great, and I think there should be a bit more of it, but it does take the maturity of someone who is put in that team leader role to be able effectively do this.
I think that unpacking of the shared mental model is powerful, and you're right. Making explicit what otherwise is implicit, because I think there's a lot of bias heuristic and again, presupposition when it's not made explicit. And I think that and that's when errors creep in to the system, is when it's not made explicit that, guys, I'm going to share the mental model. I expect this and this of the room, that people are quiet when someone comes in, but almost like you said, setting the expectations, setting the information boundaries, but also you're right, overtly sharing the mental model, but then also getting from the room. Something you said there, Andrew, which is really quite powerful, is around questioning the questioner. So not being afraid to receive questions from across the room, from juniors, from middle grade, from seniors, because there is information entropy, and there's also this fundamental lack of, we call it the sort of the invisible gorilla principle. Not one person can pay attention to every piece of nuanced information, and there's pieces of information that maybe junior doctors or junior paramedics or junior nurses will see, because we are unifocal beings. We're not multifocal. We don't assimilate all pieces of information from the room. But sharing that mental model allows you to know where my unifocal attention is in the room, so that you can cover off the lack of my multifocal ability, that my information entropy is visible to you because I've shared the mental model. And I think that's a really powerful principle that's at work here.
And also understanding how people think, and a really tough book to read, and it took me 2 or 3 times to get into it, to get going, is, Thinking Fast and Slow by Daniel Kahneman. Being able to understand that, we all are functioning on that, type 1, thinking fast, quick, make decisions, get on to where we need to go, versus the thinking slow of having to go through a process or a pathway and questioning what we're doing. But it can be challenging, and I think some simple things to do it is to have structure. One of the things that one of our registrars, who's now a consultant, Alex Jones, great guy, who helped with a lot of the study that we did for this talk, he got together with some of the registrars and other consultants in our service and put together a structured hospital handover. And again, having a format to go by is not just having key information down, but if you get lost, to have some titles on the page to recenter you, to be able to bring you back to where you're going. Because let's face it, not everyone from a personality point of view can command a room of up to 20 people with the gravitas that they need to get that message across. Whereas if you flatten the hierarchy, take age and sex out of it, take experience out of it as well, you're imparting key information that you are the holder of. You've got it in a format, and if you get a little rattled, you've got a way to actually recenter yourself by looking at the information that's on your sheet. Anyone that feels that they have to stand up and give a performance without reading notes, they need to start again, because it's just like the old days of people saying, I don't need a checklist. And we know that checklists decrease errors. We've learned that. We've put that one to bed many years ago now. But from a handover point of view, you're sitting in a helicopter, you're sitting in an ambulance, you've got the information, the patient's not dying on you right at this minute. You've got that time to actually look at the notes, or to write a quick note down, to actually then practice what you're actually going to do. Especially, if everything's been done in the helicopter and you're sitting there for a 20-minute, flight. I guess in Australia we've got the tyranny of distance, so most of our helicopter flights are a lot longer, and our fixed wing flights are certainly a lot longer than what we'd have in Europe. But I do like the way Alex put together, a structured hospital handover that has recentering questions as well as key information on it. And that allows you to get what needs to be got across in that succinct time frame and reproducible.
So, Andrew, you mentioned within the presentation the Australian Commission on Safety and Quality in Healthcare, Standard 6, around the systems should use governance and leadership. They should use as a clinical handover process. And finally, patient and carer involvement as well in the process of handover. Could you maybe unpack what governance in handover might look like?
Yeah, and the reason I use the Australian Commission of Safety and Quality for Healthcare is that is the kind of the mantra by which the hospital networks and the ambulance service that I work for, South Australian Ambulance Service, first ambulance service to actually put themselves through a hospital framework to get the standard which they were able to do. So Standard 6 about clinical handover. The reason being is that from the Australian perspective, ISBAR, was kind of looked at as the main tool. Now, ISBAR is great. We know the history coming from SBAR with the handover to nuclear submarine commanders, and we know that ISBAR fits a framework that telephone handovers within the hospital. But one of the things it doesn't fit, and that was specific about what we were talking in London, is it doesn't meet the succinct needs of a trauma handover. But what it does, it says that we need a clinical handover, and we need a clinical handover that has clinical governance, so that we need to know that the framework that we're using is supported throughout the healthcare system. By that, I mean that, it's not just a process of handing over and looking after a patient. It's a process of auditing what we're actually doing. It's a process of having a trauma audit, looking at the trauma audit, not only in key performance indicators such as time to CT or time to operating theatre or the such, but more along the lines of, did the handover give us what we need? What was the patient outcome? How can we improve that? And how can we feed it back? Now, governance in that respect is not just looking at what happens within the hospital. And this is hard, but, I think we've cracked the egg in Adelaide with the trauma service and also with the pre-hospital and retrieval medicine service. It's having multidisciplinary longitudinal audits to look at how each of the healthcare professionals that were involved with touching a patient did what they did and how that contributes to the outcome. So the governance there is looking about the processes that the pre-hospital team did, from either volunteer ambulance officers to paid crew to going on to retrieval teams, and then how that impacts to the emergency department, the trauma team, handing over to a surgical team, onto the ward, rehabilitation, and being able to capture that to know that we are not looking at one isolated piece of the patient pathway and patient care. Governance looking at the whole system and trying to make it better so that nothing falls between the cracks as we're going. The difficulty with ISBAR from a trauma handover point of view is that whilst there are some studies out there saying that, whilst people felt good about doing an ISBAR handover and receiving an ISBAR handover, when you actually looked at the notes and the patient's clinical condition, the information wasn't accurately portrayed. A story was given, but it wasn't actually capturing what needed to be captured. And so, one size doesn't fit all. I think you need to look at tailoring to your system. And we talked about this earlier. What does the healthcare system want? What does the pre-hospital system want? And how do those two meet in the middle so that they're talking effectively between them and it's acceptable? And I've showed a couple of shots of, if we're calling in from an ambulance or calling in from a helicopter, there is a chart in the resuscitation room next to the radio that information that is given pre-hospital can be written down in a reproducible format so that the capture of that information is likely to be high. And hopefully by capturing the information that is given pre-hospital before the patient arrives, we can decrease the bias by giving the full story and having the right amount of information that's handed over. So whilst I think standards are great, and I think having a structure within the healthcare system. It's only good if it's tailored and it works to those parts of the system that have trained on it and have talked to each other about what they want to receive.
Interestingly, at the moment, there's trials going on in the UK where what they're doing is calling a handover in from the pre-hospital environments, but then there's real-time data coming screened to the hospital. So as we were saying before, this trended data could be seen. I think the problem within hospital at the moment is people are fundamentally time poor, and it's not that you can just have a head nurse or indeed a sister or of the resource room, or indeed a middle or senior grade doctor sat in front of a computer watching the trended data, but trying to get some semblance of trended data before the patient comes in, so that they can see any maladjusted or poor physiology as it's coming in. But absolutely, I think the way we engage with information needs to change. So there's systematization, so there's reproducibility, and indeed there's some semblance of consistency over time, so that and almost offloading the weight of everything has to occur in one snapshot time. And I think, Andrew, that really brings me along to sort of the next question, because in your fantastic presentation, you showed a video of a recorded handover and the information entropy which is lost in the room, and the lack of transfer of information. To your mind, Andrew, how could we monitor the process of handover in a consistent, and indeed the quality of handover in a consistent fashion?
Good question, and tricky to answer, because again, it depends where you are and what your resources are. I like the method of videoing and playing back. I also like the method of running simulations whereby the focus isn't on doing something clinical, but it's more focused on the handover within the room and active listening. It's interesting when you have kids, you talk about them to listen. I keep on saying to the kids, you've got one mouth and two ears, so you should be doing double the amount of listening. But it's really interesting when you watch a room and you see that people aren't listening. Sunnybrook in Toronto, where I spent some time, they do it well. They've got a resus room that is a sim resus room that's only do sims in. And so they've always got the ability to run a sim. And I think, the University of Adelaide has got a good setup where they've got a whole lot of sim rooms and they can practice this over and over again. So you need to, probably set the scene by, some didactic lectures or podcasts or online learning, as part of your hospital or pre-hospital setting. Then you need to put it into practice, because you need to actually be the person giving or receiving of the information, and you need to understand how that felt, and you need to understand it's not about you, it's about the information, and that you're being a patient advocate by trying to get that information across. So I think there's many different ways to do it. Videoing is one, and we do that. Running simulations and then debriefing the simulations, practicing as a team. Also making it part of the audit, and we certainly look at it from our MedSTAR pre-hospital audit on a Thursday morning, where we ask the team that are in the room, what was your reception like, and were there any barriers? Did things go right or wrong? Because being, a small town like we are, 1.5 million, with only a few trauma centres, it's really interesting to be able to feed back. And, the consultants that work in our service also work in the trauma service, working in the ambulance service. So those linkages are really good, and that breaks down some of the barriers as well. Because it's never about questioning someone's clinical ability or their decision-making. It's more about having the clarity of a handover in a process that can be easily digested and reproduced without errors. And I think that's what we're trying to distill it down to.
So just before we come into land on the conversation, actually, Andrew, and just look at a few take-home messages, if you could maybe speak to, you've mentioned a few tools already, the SBAR and AppMist is another one, and a couple. Maybe if you could just mention sort of the saliency of a tool, because you're right, different systems will use different tools, but from your experience, what works in practice within sort of the application of a tool? What have you seen work in practice from the application of a tool?
I've seen people getting it right, and I think, if we want to break it down to the most basic way, from a trauma perspective, MIST is probably, we all know the MIST, or HIST if it's medical, but looking at the mechanism, looking at the injuries, the signs, and the treatment, adding in the introductions, I think, is key. And we haven't really touched on that, but one of the other ways to break down barriers, it's so simple to walk into a room and just blast it all out, but the ability to introduce who you are and who your team is, and the patient, that certainly gets people on side a lot easier. Having a name to relate to, I think, is good. The structure is probably the key from any of the handover tools, and I put a lot up, and it's interesting, the more letters you put there, the more difficult it is to remember all the different bits that it is. And even, with an AppMist handover, as I showed, that the Scots have got, looking down through going, age, time, mechanism, injury, signs, symptoms, treatment trends, but then they bolt on some others down the bottom, that aren't in AppMist, with allergies and, prescribed medication. So really, it's not capturing it all. And I think trying to be fancy and have a catchy name or title or acronym, that can make you come unstuck as well. And that's why I like what Alex Jones has done with the team at MedSTAR, is having, the immediate needs. For us, we wanted to know COVID status as well in these COVID times. The age, the time, the mechanism, the injury, illnesses, the GCS pupils, limb movements, the treatments, and then the thank you at the end. So that they're the centering questions, and then the information that you put off on that, and having it in a format that you can have it in your hand to actually relate to, because you don't need to memorize all this stuff. You can refer to things, and I think having one system, so that you're not coming in every time with different people having different systems. And that gets back to what I said very early on, is the healthcare system and the pre-hospital system should be able to talk together to understand how they want to receive this information. And again, it works kind of well here, because our ambulance service that I work for is also part of the same Department of Health that is the hospitals as well. And we have those linkages, through trauma audit and retrieval audit. It's as simple as having a framework that you can rely on and go back to and look at without having to talk off the top of your head. It's speaking a language that everyone in the room understands, and it's not trying to be too fancy. Really, you don't want to overcook or over-egg the pavlova. You just want to get the basics out. Hopefully your notes are good and you've had the time to do it. And I know, as we talk about electronic patient records and push and pull of information, but again, if you've been on a very busy primary trauma, you might not have written your notes. You might not have had the information electronically in the case card to push ahead. So the team has to have something to hang its hat on and to hand over to the receiving team. And that's why this structure that we're talking about, and basic structure that gives the information that is going to make a difference to how that patient's treated in the next 30 to 60 minutes.
Listen, Andrew, that's fantastic. And just actually something you said there, which I just really twigged to my memory around sort of this kind of principle of verbal midazolam and de-escalating the scene, is certainly in the pre-hospital environment, where you just introduce yourself, say, how can I help? You know, what's happening, guys? How can we help? And it's this simple introduction of your name at the respective clinician's line of sight, so not towering down, and supplementing their care through your de-escalation, trying to consistently de-escalate the room, the scene, the other clinicians in the room, and actually starting off on that foot, Andrew, is powerful, because what it does, as you said, it sets the tone, it sets the expectation for, actually, this is going to be okay. And most of it's all nonverbal, and it really puts other people at this sort of subconscious ease and rest, that actually we're going to figure this out together. I'm here to help you. We're going to do it in an expected cadence, and we're going to be over in our communication style. And actually, that sometimes isn't taught. It's really hard to teach that, actually, and it comes through rehearsal and exposure to consistencies, and to people and practitioners that do it really well. And as we've probably both seen this, clinicians that you get to see, and their non-verbal language speaks immensely loudly, and it really de-escalates the room. Could you speak to that?
Yeah, and you've just raised a point that I'm thinking about as well, as the theatrics of it all. When a retrieval team comes in, in London, bright orange suits; in Adelaide, bright red suits. It's a challenge, because again, you've got an interplay between the trauma team accepting, the pre-hospital team handing over, and again, how you speak to people makes an enormous difference. You look different because of your uniform, and your uniform, for me, it stands out because we need to stand out at a scene. We need to be safe. We need to stand out at a hospital. We need to realise who is the retrieval team, who are the people to go to, and what is their role, because you've got your role written on it. And that's a little bit different to the hospital, where everyone's in their scrubs, depending on where you are. We use stickers that have the different roles and responsibilities that get put onto our PPE with our names on them as well. But breaking down those barriers of introduction, being able to look people in the eye, being able to resonate with reading the room, because again, some of the subtle things we haven't talked about. You go into the Royal Adelaide Hospital, there's 8 resus rooms. The hospital's on, code white. The ramps full of patients in ambulances, and they've been thumped. And now you're bringing in another patient. You don't know what they've had to deal with before you got there. You're focusing on your patient, but you need to be respectful that you're coming into their place. You're giving your handover, and your patient, yes, is important, but how does that fit into everything else that's going on around them? And trying to read that room to be able to, as I said, resonate with who's in the room, to get the right information across at a respectful level, realizing that sometimes a uniform can prime people up to different responses. Or here's the retrieval team all decked out in their fancy uniform. It's not a retrieval team decked out in a fancy uniform. It's safety PPE, for their role. But everyone's got those different expectations, and it's being able to understand how it fits in. And that's why, we talk about teach, train, do sims, record it, review it, collaborate with other centres. And the golden egg for all of this is being able to publish the data, like some of the data that I've talked about, and some of the great papers that are out there, like, Jez Losby's paper, from several years ago now, from Kent, Surrey and Sussex, and the work done out of the Alfred with Mark Fitzgerald and Sue Evans and the team there. All of this stuff helps us, and a lot of it's not rocket science, but it needs to be revisited, and it needs to be worked upon and talked about, and lay it on a framework of good clinical practice. And it's not as simple as we think, but it shouldn't be as complex as we think either. So we need to make it attainable to the staff that are doing it. And I think senior leaders in each of our roles need to be able to pass this on and actually work on this and make it something that is important, because we are being the patient advocate. We don't want to lose that clinical information. The patient that has had a fall and has had a bleed from the scalp, there's blood loss at the scene, there's blood loss in the ambulance, there's blood loss in the helicopter, there's blood loss in the ED, and then that patient's in CT with a blood pressure of 70, and no one's known all of those different amounts of cumulative blood loss that have happened along the way. You're the person doing the handover that needs to be able to capture that and portray that so that it makes it safe for that patient going to CT, rather than that patient going to CT with a blood pressure of 70 for a normal CT, but a scalp lac that actually has caused most of the trouble.
So listen, I think what we'll do, Andrew, is put in the show notes the relevant empirical literature and indeed the references to the literature which you've mentioned, because I think it's fantastic, and it would be a nice referral and supplement to the interview. So we'll certainly do that. Just as we come into land, Andrew, could you maybe just speak to some take-home messages, maybe 2 or 3 take-home messages for people as they finish listening to the interview?
I think the most important things that we've talked about is having a simple, reliable structure that meets the needs of the pre-hospital and the hospital, that is quick, easy, reproducible, that can be audited, that also can be adjusted to meet the needs of the patients, that is practiced, it is evaluated and is fed back, and is done in an environment that we can actually research as well to get the message out, so that we do have the best process in place to get a clear message across in a succinct timeline of what should be done for our patients.
Listen, that's fantastic, Andrew, and a really nice synopsis of the interview. Thank you for your time and insights, as they're both insightful, but also fascinating from your anecdotal experience as well as the literature. So thank you. Thank you very much, Ian, for taking the time. It's been great having a chat.
Listening to the Pre-Hospital Care podcast on the Medics Academy Network.